Kamilan, organizing secretary for this program, faculty of the university, the various faculties who have accompanied the delegates to this important and historic occasion. It is my pleasure to welcome you all. Our Vice Chancellor, sir, had visited his center in Trivandrum and was shown around the various activities of the particular center. And it is just to start new courses in this university. Our Vice Chancellor, sir, has invited Dr. Rajagopal and team to be here today with us. This is a very huge gathering here. This hall can house close to 1,000 people. More than 720 have registered all over the state, sir. It is due to your extraordinary skill that you are going to exhibit today. We welcome you again wholeheartedly, sir, on behalf of the Vice Chancellor and all the members of the university. I welcome the speakers who have taken time to be here. Ever since our Vice Chancellor took charge in June this year, he has been trying to convert this university from being an administrative unit to a research center of excellence. The announcement of the building of a 100 crore research center in the university, the chairing of the to-be international conference to be held in January, where we are expecting delegates and staff from all over the world. We have opened an intellectual property center in the university. We have released 3 new research journals of national standard. And the list will go on. Vice Chancellor personally went around nearly 16 or 17 universities in the state and visited centers of excellence like PGI, Chandigarh, M.G.R, Vaidehi Institute, Bangalore, and so on, to get the best practices from all the places. Towards the same, he has been encouraging newer concepts into the thought process of the university and its affiliated institutions. I take this opportunity to thank you, sir, for providing this platform in this university today. I hope all of you will realize the importance of having the best man in the country in this room here today to talk about palliative care. Once again, I welcome you all wholeheartedly and hope you have a wonderful time today. Thank you.
நமது பல்கலைக்கழகத்தை அடுத்த பரிணாமத்திற்கு எடுத்துச் செல்லும் நமது மாண்புமிகு துணைவேந்தர் அவர்களை தலைமை உரையாற்றும்படி அன்புடன் கேட்டுக்கொள்கிறேன்.
Most respected Padmasri Dr. M.R. Rajagopal, Chairman Emeritus Palliative India, Toronto. Welcome, sir. And respected our Registrar Dr. Ashwath Narayan, and respected Professor, Head of the Department of the Siddha of the University, Dr. Kabilan, and respected today's key speakers in the workshop, Dr. Radha Venkadeshan and Dr. Mallika Thiruvadanam. I am honored to be on the dais to preside over the function, the inaugural function of the workshop of palliative care, jointly being organized by the Dr. M.G.R Medical University and the Palliative Care Toronto. Whether you might be knowing or not, you must come to this position to know about it, because it's the need of the hour. What is a palliative care? It is one of the integrated part of that is a medical care, one of the discipline where you must have go through that so that you can have a learn and a practice. So most of the important aspect of the health care or pallium is one of the primary care to be given that. So palliative care is an interdisciplinary medical caregiving approach aimed of quality of life and to mitigate the sufferings among the people affected with the terminal illness. But the WHO describes a palliative care is an approach that improves the quality of the life of the patient and their families also facing the problems associated with the life-threatening illness. In the past, palliative care was a disease-specific approach. But today's the WHO takes a broader patient-centered approach to be applied as early as possible, but any chronic ultimately fatal illness. So to initially it was be the palliative care was the end of the care. It is not like that. Nurturing at the beginning, nurturing of the care. So you must have, I think, this workshop going to have a detailed your view about your palliative care. You have to demonstrate. They have to give us a very good breakthrough in our palliative care learning and followed by a service. So we have planned to have a start of next academic year will be the NMC approved MD Palliative Care, and parallelly, consequently, we are going to start with the BSc Palliative Care. This is one of the wonderful opportunity for those who have been undergoing these two courses. Medical postgraduates, they can enter into this MD Palliative Care, and those having allied health science, they can enter into the BSc Palliative Care. So they have a lot of opportunity for you in the future to render your services to the patient need of. So the palliative care is provided by the interdisciplinary team, which includes physician, nurses, occupational physician, physical therapists, psychologists, social workers, and so on. Is team split. With the team split only, we can have a provides comprehensive care. The evidence supports of the efficacy of the palliative care approach in improving the person's quality of life. I am very happy to today we have in our midst Padmasri Dr. M.R. Rajagopal, Chairman Emeritus Pallium India, an organization dedicated for palliative care since 2003. As a collaborative with the palliative care from the university, we are going to have spread the awareness and sensitize the essential need of palliative care in the Tamil Nadu. In future, I said the two courses will be started. I think I congratulate the organizer, made arrangements for this delegates. I think more than 720 delegates has come to today's program. The various from various disciplines, not only is from this modern medicine, also it have taken care with the other Ayush, dental, and nursing. Everybody has come. It is very happy to see that. I think we have make this interdisciplinary approach. However, the availability of the palliative care of this affected patient is not known to the people living in rural areas and villages. Considering the importance attached to the palliative care, this university is taking a steps to popularizing this facility through the academic courses and the conduct of workshop like this. The university attaches more signifies of palliative care because the 1%, the less than 1% of the population in India has access to palliative care and pain relief. The palliative care is able to improve the healthcare quality in 3 sectors. One is a physical and emotional relief. Second is a strengthening of the physician-patient communication and decision making, and the coordinated continuity of care across the healthcare settings, including the hospitals, home, and the hospitals. So, with these few words, I wish the speakers of the workshop would enrich the delegates on the topic and the outcome of the same would benefit to the society at the large. Thank you very much.
சிறப்பு விருந்தினர்களுக்கு மரியாதை செய்யும் நிகழ்வு. நமது மாண்பு துணைவேந்தர் அவர்களை பத்மஸ்ரீ டாக்டர் M.R. ராஜகோபால் ஐயா அவர்களுக்கு மரியாதை நிமித்தமாக பொன்னாடை மற்றும் நினைவு பரிசை வழங்குமாறு அன்புடன் கேட்டுக்கொள்கிறோம். நிகழ்வின் ஒருங்கிணைப்பாளர் டாக்டர் ஸ்ரீதேவி வாரியர் அவர்களுக்கு பொன்னாடை அளிக்குமாறு அன்புடன் கேட்டுக்கொள்கிறோம்.
வணக்கம் டாக்டர் நாராயணசாமி, colleagues, my colleagues and your colleagues and dear friends. I don't know how many of you are here, many hundreds I hope. Among these there must be at least 100 people who have had the experience of a loved one going through serious illness in your own home. You must have struggled. You must have come to doctors like us and we would have treated the diseases. You would have gone back home carrying the burden of pain and suffering in you, which as medical professionals consistently we have tried to avoid. It was not deliberate till we got a framework to address the suffering. We were at a loss. The only way we could survive as professionals was to turn away from suffering. But now, what you are going to learn today will at least make the beginning of a change. You will stop seeing only the diseases. The person, that case of carcinoma, that case of bronchopneumonia, that kind of approach will stop. You will learn to look at human beings and not only diseases. You will stop seeing human beings as containers of diseases. You will start seeing them as people with emotions, people whose tears matter, people whose feelings matter, and you will know how that can be faced, how that can be addressed. And that learning, friends, will not only be useful for the hospital, that learning will help you when your own parents have any illness, your grandparents, uncles and aunts have any illness. And eventually, we all, every one of us, will be ill someday. And whatever you learned here today will matter at that time. So I have given a very tall promise, I know, that in a day, many new useful learnings will be there. My colleagues and I will try to fulfill that promise over the day. Dr. Narayanaswamy, my journey in palliative care has been over roughly 3 decades, just as it has been for Malliga also. I've never ever seen in these 30 years somebody with pure combination of pragmatism, sincerity, and action-oriented approach. In a short while, since you have been introduced to this field, you have done wonders. And because of you and your colleagues, my hope for the future of healthcare in this country has soared sky high. Thank you for being in this world. And I am immensely grateful to Dr. Soumya Swaminathan, former Chief Scientist of World Health Organization, for introducing you to our work. She could not be here in Chennai today, but I am sure she is wishing us well. So, everybody, thank you for being here, and thank you all once more.
மரணம் இயற்கையானது, தவிர்க்க இயலாதது. இறக்கும் நிலையில் உரிய ஆதரவை தந்து, தேவைப்படும் அரவணைப்பை தந்து, உலக மனித உயிர் பரிமாற்றத்திற்கு காரணிகளாய் இருந்த நமது முன்னோர்களை நன்றியோடு வலியை குறைத்து வழி அனுப்பும் பேலியேட்டிவ் கேரின் மூலமாக மணலை போல் காப்போம் என்று கூறிக்கொண்டு இந்த விழாவினை சிறப்பாக ஒருங்கிணைத்த செய்யும் செயலில் முத்திரை பதிக்கும் எங்கள் பல்கலைக்கழகத்தின் சித்த மருத்துவத்துறையின் தலைவர் டாக்டர் என் கபிலன் அவர்களை நன்றியை நல்குமாறி அன்புடன் கேட்டுக்கொள்கிறோம்.
சார்ட் நோட்டீஸ்ல பத்மஸ்ரீ டாக்டர் M.R. ராஜகோபால் அவங்க வந்து இந்தியாவின் தந்தை ஃபார் பாலியேட்டிவ் கேர் அப்படின்னு அவங்க வந்து கவர்மெண்டே வந்து அவங்க பாராட்டு தெரிவிச்சிருக்குது. ஸோ அவங்களும் வந்து ஷார்ட் நோட்டீஸ்ல அவங்களுடைய பிஸி ஷெட்யூல்ல இன்னைக்கு காலையில் ட்ரிவாண்ட்ரத்துல இருந்து வந்து இவ்வளவு தூரம் வந்து நம்மளுடைய உரையாற்றுவதற்கு அவங்களுக்கு முதல் நன்றியை தெரிவித்துக் கொள்கின்றேன். ரெண்டாவது, இந்த ஒர்க் ஷாப்புக்கு முழு ஒத்துழைப்பு நல்கிய ரிஜிஸ்ட்ரார் அவங்களுக்கு வந்து என்னுடைய முதல் நன்றியை தெரிவித்துக் கொள்கின்றேன். திடீர்னு பாதியில் இருக்கும்போது தான் MOU போட்டால் அடுத்த ஸ்டெப்புக்கு நல்லா இருக்கும்னு பிசி சார் சொன்னாங்க. ஸோ அதை வந்து வித்தின் 1 வீக்குள்ளே தான் இந்த MOU ப்ரோக்ராமை வந்து கன்ஃபர்மேஷன் பண்ணினது. ஸோ அதுக்கு லீகல் செக்ஷன், நம்மளோட வைஸ் சான்சலர், ரிஜிஸ்ட்ரார், பாலியேட்டிவ் இந்தியாவோட சேர்மன், கோஆர்டினேட் பண்ண டாக்டர் ஸ்ரீதேவி வாரியார் அனைவருக்கும் என்னுடைய நன்றியை தெரிவித்துக் கொள்கின்றேன். இந்த ப்ரோக்ராம் ஷெடியூலில் ஃபுல்லாகவே கோஆர்டினேட் பண்ண வந்து டாக்டர் ஸ்ரீதேவி வாரியார் அவங்களுக்கு முக்கியமாக நன்றி தெரிவித்துக் கொள்கின்றேன். மற்றும் வந்து 2 ஸ்பீக்கர்ஸ், அதாவது மொத்தம் 4 செஷன் தான், ரொம்ப ஒன்றும் போர் அடிக்காத செஷன் மாதிரி அரேஞ்ச் பண்ணியிருக்கிறோம். 2 செஷன் வந்து டாக்டர் M.R. ராஜகோபால் சார் அவங்களே பேசுறாங்க. அதுபோக 2 செஷன் வந்து டாக்டர் ராதா வெங்கடேசன் ஃப்ரம் பாலியேட்டிவ் இந்தியா, இன்னொரு செஷன் வந்து டாக்டர் மல்லிகா திருவதனம், ஃபவுண்டர் ட்ரஸ்டி லட்சுமி பைனன் பாலியேட்டிவ் கேர், சென்னை. ஸோ இவங்களை பற்றிலாம் நமக்கு முன்னாடி தெரியவே தெரியாது. இந்த ஒரு 1 மந்த்ல பாலியேட்டிவ் கேர்னா என்னன்னு எங்களுக்கு தெரிஞ்சுக்கிட்ட முதல்ல, அதாவது எப்படிலாம் வந்து இந்தியாவில் வந்து எவ்வளோ கஷ்டப்படுறாங்க மக்கள், அதுக்கு வந்து எவ்வளோ தூரத்துக்கு வந்து இதை வந்து இவங்க ஹெல்ப் பண்றாங்க அப்படிங்கிறது இவங்க மூலமா எங்களுக்கு தெரிஞ்சுக்கிட்டது. ஸோ இது மூலமா உங்க எல்லாத்துக்கும் தெரியும்னு ஒரு ஆசை. இது மட்டும் இல்லாம இதனுடைய ஃபாலோப்பா நிறைய ப்ரோக்ராம் பண்ணலாம்னு அப்படின்னு இருக்காங்க பிசி சார் அவங்க. அதாவது இப்போ வந்து அலையட் ஹெல்த்ல வந்து நிறைய கோர்சஸ் இருக்கு. அதில் பிஎஸ்சி பாலியேட்டிவ் கேர் அப்படின்னு ஒரு கோர்ஸ் வந்து ஆரம்பிக்கிறதுக்கு நெக்ஸ்ட் ஸ்டெப் எடுக்க போறாங்க. அது மாதிரி NMC அப்ரூவ்டு MD பாலியேட்டிவ் கேர்னு ஒரு கோர்ஸ் இருக்குது. பட் தமிழ்நாட்டில் வந்து இது வரைக்கும் எந்த கோர்ஸுமே தமிழ்நாட்டில் இல்லை, அந்த கோர்ஸ் எந்த காலேஜுமே இல்லை. ஸோ அதை ஸ்டார்ட் பண்ணுறதுக்கு அடுத்த ஸ்டெப் எடுக்க போகிறோம். ஸோ இப்படி பல விதத்துலையும் இந்த பாலியேட்டிவ் கேர் வந்து புது முகத்தோட தமிழ்நாட்டுக்குள்ள இது வரைக்கும் தெரியாதவங்களுக்கு தெரிய வைக்கிறதுக்கு வந்து முழு முயற்சி எடுத்துக்கொண்டிருக்கிறோம். ரெண்டாவது, பிசி சார் வந்ததுக்கு இது 3வது ப்ரோக்ராம், அதாவது ஒர்க் ஷாப் முறையில் எல்லாம் வித்தியாசமான டாபிக். ஒன்று வந்து IPR, அது வந்து யாருக்குமே புது டாபிக் ஒன்று. ரெண்டாவது பயோ எத்திக்ஸ், இது 3வது வந்து பாலியேட்டிவ் கேர். ஸோ பிசி சாருக்கு அவருடைய விஷனுக்கு எங்களுடைய நன்றிகளை தெரிவித்துக் கொள்கின்றேன். அது மட்டும் இல்லாமல் ஷார்ட் நோட்டீஸ்ல எல்லா இன்ஸ்டிடியூஷனுக்கும், அதாவது அரௌண்ட் சென்னை மட்டும் தான் நாங்கள் வந்து அனௌன்ஸ் பண்ணிருக்கோம். சென்னையிலேருந்து மட்டும் தான் மேக்ஸிமம் அரௌண்ட் சென்னை தான் வந்திருக்கிறாங்க. ஆல்மோஸ்ட் 701 ரிஜிஸ்ட்ரேஷன் நேற்று நைட்டு வரைக்கும் 701 ரிஜிஸ்ட்ரேஷன். இதுல மெடிக்கல், டென்டல், ஆயுஷ், நர்சிங், பார்மசி, அலையர்கள் இவ்வளோ காலேஜ்ல இருந்து எல்லாம் வந்துட்டு நீங்க. ஸோ உங்களோட பிரின்சிபால், அவங்களோட மேனேஜ்மெண்ட், இதுக்கு எல்லாம் ஹெல்ப் பண்ண எல்லாத்துக்கும் நன்றி தெரிவித்துக் கொள்கின்றேன். கடைசியாக எங்க டிபார்ட்மெண்ட் ஆஃப் சித்தாவில் உள்ள ஃபேக்கல்டிஸ், அவங்க சப்போர்ட்டிங் ஸ்டாஃப் இல்லாம வந்து நடத்த முடியாது. ஸோ அவங்களுக்கு நன்றி தெரிவித்துக் கொள்கிறேன். அனைவருக்கும் நன்றி தெரிவித்துக் கொள்கிறேன். நன்றி, வணக்கம்.
Your patient is to mitigate suffering. Mitigation means preventing and treating suffering. That's the first sentence. What percentage of diseases do you think can be cured? Of all the patients coming to you, majority or minority? Only about 1/3 of all diseases can be cured. Oh, we can help people to live with many other diseases. But everybody will need relief from their suffering and also need to be comforted. And see the last sentence. There exists no exception to this rule. There is no situation where you do not have the duty to relieve my suffering. And the numbers of people with serious health-related suffering, 1 crore of people around the country are in suffering. Serious health-related suffering. I am happy to share this deck of slides with anybody. In the bottom, you will see a Lancet Commission report reference. For anyone who cares to, I would encourage you to read at least the executive summary. It's a long document, even if you cannot read everything, read the executive summary. When this report was published, Dr. Richard Horton, who is the chief editor of all Lancet group of publications, wrote, medicine will never be the same again. Because this lists out the numbers of people roughly across the world, country by country, lays out the nature of diseases which cause such suffering. Many people think palliative care is only for cancer. No. It doesn't make sense. We should have to have cancer to earn some comfort, to earn some relief from pain. The disease cannot be used as a condition for discrimination. This report is also fairly recent. It came from Worldwide Hospice and Palliative Care Alliance. If you look at it, you will find that only 28.7%, 28.2 plus 0.5 are of cancer. There is a next large group of HIV and a frightening percentage, 12 plus percentage of dementia. Horrible thing to have. If God comes to me and says, hey Rajagopal, choose between diseases. I'll choose anything other than dementia. If he asks me to choose only between cancer and dementia, I'll choose cancer. Those suffering of those people is enormous. I said there must be 100 people who have gone through serious suffering in your own homes. And every one of them will realize that it is not only the patient who suffers, the whole family suffers. The whole family suffers physically, emotionally, socially. And those people suffering, it is for us to relieve as much as possible. And remember, we live in a country where 1/5 of all suicides are because of health reasons. Health-related suffering is the cause for more than 29,000 people every year according to the National Crime Records Bureau. And you can imagine that in our country, the reporting to the National Crime Records Bureau must be minimal. There must be many left out. But if they find that we will have to take care of this 29,000 plus people who found it too difficult to live. But we'll talk about this aspect later in detail in my second session. But I'll just make a beginning with this statement by Dr. Sankha Mitra, who is an oncologist who does charity work in the northeast of India. He says in India, the poor die of misery of neglect. The middle class die in misery of ignorance. But the worst suffering goes to the rich. The rich die in misery on ventilators. Death being stretched out, dying being stretched out over a period of time, adding suffering, physical, emotional, and social suffering. And Sankhamitra says, no one gets a pain-free and dignified death. This is something a bit different from what I earlier mentioned. Earlier I was saying that people's suffering is not relieved. Now here we are showing that we actually add to suffering. I was an intensive care doctor at one time. I know that intensive care is very valuable in very serious illness. But when it is used to stretch out the dying process in futile treatment, it's a cruel punishment that should never happen. There is no justification for that. The National Cancer Grid, I don't know that some of you have heard of it. It's a conglomeration of more than 300 cancer hospitals in the country, headed by Dr. C.S. Pramesh of Tata Memorial Hospital. And together they declare, do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. The cancer hospitals, cancer specialists in the country are declaring that for people dying from cancer, ICU unit should not be the place. But look around you, what's happening all around us. How can we justify this? We'll talk about end of life care more later. But this old point I'll mention right at this stage. This is not global. You see two panels. These are both fairly recent publications. The first panel shows European figures. That report is from European Union countries, where when treatment is useless and treatment is futile, 90% of people are taken out of life support systems, ventilators or ECMO or whatever, and instead given palliative care. Whereas in India, strangely, where we cannot afford it, 70% of people are continued on those ventilators till eventually the heart gets tired and stops. There is no moral, ethical, or legal justification for this. We'll talk about this also in detail later. But here is another cruelty that we are doing to your patients. You are becoming party to it. You and I are part of the problem. 55 million, 5.5 crores, more than 4% of our population are going below poverty line by catastrophic health expenditure. India is among the worst 12 countries as far as this destruction is concerned. By being a healthcare provider, you and I are party to the problem. And it's up to us to find a solution and minimize this destruction. Earlier, I defined palliative care as prevention and treatment of suffering. Just remember that, that's great. Here is the official definition from World Health Organization, which is about 1.5 kilometers long. So, because it's too long and a binding sentence, I have given a different color to some phrases. It's about quality of life. Earlier I said, ordinarily you are looking at diseases and organs. You are looking at the temperature, pulse, BP. You are not looking at what they feel. This is about quality of life. Your duty and mine is to improve quality of life of the patients and their families. How? Whenever they have a life-threatening illness, we prevent and relieve suffering, which may be pain or other physical symptoms. Think of other physical causes of suffering. Breathlessness, nasty fungating wounds, many. By early identification and impeccable assessment and treatment, etc., pain and other physical symptoms, psychological, social, and spiritual issues. And the World Health Organization adds, friends, this is important. This is very important, please listen. This is not only for the dying people. Palliative care has to start early in the course of illness. That is, Dr. Raja Meyer, who is a pulmonologist, chest physician, when she sees a patient, it need not be a dying patient at all. When she sees a child with asthmatic bronchitis, she looks at the suffering in the child and suffering in the parents also. That's application of palliative care early in the course of illness. Later during the session, you will have a detailed description of how pain is to be treated. That's how you are doing it, right? How pain is to be assessed and treated. This morning, first I said your lives are going to be changed. All the nurses hereafter, when you are doing your TPR in the morning, you will also learn to ask, are you in pain? And then you will find out the nature of the pain. Sir, two hospitals, cancer hospitals in the country, one cancer center, Silchar in Assam, headed by the Max Award winner Dr. Ravi, and the other is the Cancer Research Institute in Dehradun. These two are now pain-free hospitals. We can do it. In every hospital under this university, we can do it. Where when you check the temperature, you also ask, are you in pain? If they say yes, the score of pain is written and somebody addresses the pain. I showed this picture. I'm not, Radha will discuss this in detail later. But only thing is, in the top ladder, you cannot treat moderate to severe pain in many conditions, including cancer, without access to opioids like morphine. Law has been modified in 2014. It's possible to have access to morphine, and we have the responsibility to make sure that it is used safely. Just having morphine available widely and not documenting it, allowing misuse is not permissible. The balance between safety and access is our responsibility. In 2014 again, the World Health Assembly, that is the decision-making body of World Health Organization, came out with a resolution of World Health Assembly 67. Integrate palliative care into health systems at all levels, primary, secondary and tertiary. Dr. Rajan works in a tertiary hospital. I talked about integration into her work at the tertiary level, but also in the primary health center everywhere. From across the continuum of care, meaning from the beginning of the illness to the end. So, as an example, I'm not going to talk about every symptom. As an example, let us see how you will treat somebody who is coming to you with advanced cancer and breathlessness. Have you seen people like that? Who come to the casualty, breathing like that, unable to take in a breath? Many of you must have said, I see some people nodding. If it is asthma, it's another thing. It's treated in a certain way. They are also with compassion. But if it is advanced cancer and the breathlessness is because a large tumor is pressing on my airways, how do you handle it? You look at oxygen saturation, 67%. Quick! Will you rush me into the ICU? Don't. That is not going to solve my problem. That's going to worsen my problem. If I am dying, I need to be with my family. Don't say meaningless things. Everything is going to be okay. Instead, give me realistic reassurance. If you show with your eyes and your facial expression that you care for me, if you are compassionate, if you lay a hand on my hand and tell me, I see you are in distress, We are going to look after you. One of us will stay here till you feel better. That will relieve me enormously. And for anybody who doesn't know, breathless, they try to take harder and harder breaths. That decreases the airflow. If they are calm and peaceful and little more, they learn to breathe slowly in and out, and flow of air improves beyond belief. It is good to try oxygen. You will keep an oxygen mask on my face without talking, and I feel distress and try to pull it out. You have seen this happening all the time, isn't it? You put in a mask, the patient pulls it out. What do? Push it back and give a nice scolding. Don't take it out. The person pulls it out again. You put up a sticking plaster. The person still pulls it out. You are smiling. You have seen this happening, right? If the oxygen does not help me, I am going to be uncomfortable with a mask because it will give me a feeling of suffocation. I set oxygen trial for 10 minutes. Don't look at the oximeter in this instance. Look at me. If this is advanced incurable cancer or some disease like that, somebody is dying, if the oxygen is not going to make me feel better, what's the point? Why are you giving it to me? If it makes me feel worse, why? Before, in that kind of patient, before I put it on, or one of my colleagues puts it on, we will tell them, we are going to try this. We'll try for 10 minutes. If you feel better, we'll continue it. If you don't feel better, we'll take it out. If you explain that in advance, families also accept it. What will help me at that time is intravenous corticosteroids first. It will take some time, but it will reduce the edema, the swelling around the tumor, open up the airways a little bit, and that will help me to breathe better. And surprise, morphine, which I was once taught is contraindicated in breathlessness, becomes almost a drug of choice. Not huge doses, not 15 milligrams subcutaneously, but 2.5 milligram orally or 1 milligram subcutaneously given to me will decrease the sensation of breathlessness. In high doses, it will cause respiratory depression, but in small doses, it decreases the sensation of breathlessness. We will talk a bit more about that when we discuss end-of-life care. But please remember, I have been talking about pain and breathlessness. But at that time, my suffering may also be in the social level. Relationships. Most important to me are my children, and he is unable to come. I want to see him once more before I go. I quarreled with my brother 7 years back. I want to see him at this time. I want to tell him I am sorry. I want to hold his hand again. Do you think that's important? Isn't that more important than your oxygen inhalation at that point of time? Relationships, where you feel connected. Again, in this group, there may be some people who have moved from your village to a city, and you want to take your parents along or the grandparents along. They have been in the village, they have seen those trees and everything outside their window all their life. All of a sudden, you take them to your city, to the 45th story apartment in the middle of Chennai. They are disconnected from this world. In 24 hours, they become delirious. Relationships are important. Connectedness is important. Meaning of life is important. You must have heard old people say, what's the point of me being alive? At least some of you, a grandmother or a grandfather asking, what's the point? I wish I were dead. I'm not of any use to anyone. What would you say? I had a friend in that situation. He was going down saying, Mom, you don't have to be useful anymore. That's what she is also saying. I'm not useful anymore. It's time for me to go. Instead, if that same son held her hand and said, oh, I need you because I love you. I need your love. That would be adding meaning. All this becomes part of palliative care. Of course, in today's session, my colleagues and I cannot cover all this in detail, but at some point of time, you will learn it in detail. Friends, in medical curriculum and nursing curriculum, this has been included. Medical curriculum since 2019, and in nursing curriculum since 2022, palliative care is officially included. So we will have an opportunity to learn it. Other universities may take much longer, but not Tamil Nadu M.G.R University. It will happen now. So how are we going to affect this integration? When you see a patient, whether you are a doctor, nurse, physiotherapist, pharmacist, or anybody, how will you integrate it at all levels across the continuum of illness? If people are to get some comfort, it cannot be only through palliative care units. Of course, we will need palliative care units. The top triangle will be the limited number of patients seen by palliative care units. But see the middle part. That's where integrated palliative care by all clinicians happens. Nurses, doctors, everybody. And only difficult problems need to go to the palliative care units. In the two hospitals that I mentioned, in Assam and Dehradun, I said every patient is asked. Every doctor and every nurse has had training in pain management. Similarly, all of you will get training in palliative care. So whatever disease the patient may have, as you treat that patient, you will learn to integrate it. Now, the bottom, as you can see, the foundation there is by community action. This is very important. We must engage with the community. And only then people who really need care can get it. Once I was in a HIV hospice in northern Karnataka, Koppal district. It was a few days of great learning for me. So I joined the team on rounds. And there was this young man sobbing hysterically because he got HIV and his village had thrown him out. And here he was having physical pain, breathlessness, but also the agony of being alone in this world, nobody to care for him. And as he was crying, this Sangamitra Iyengar, who is a psychologist and runs the place, just raised her head and looked at the team. And one young man standing behind, he was a medical social worker. He was also HIV positive. Medical social worker raised his hand and said, Madam, I will go tomorrow. Sangamitra did not even have to ask. She raised the hand and the team knew what to do. So what happened there after I inquired? The medical social worker went to his village, talked to the village headman, whatever they call it, and then he called a few elders. They talked. This social worker went again after 3 days. By the next week, the villagers understood HIV. found a way of safely bringing him back. And when he was discharged from that institution, the man went back to the village. Is that healthcare? My God, without that, healthcare is very little. That was the pinnacle of healthcare. If we engage with the local community, we can make wonders happen. This is all for tomorrow. We are not used to being engaging the community. But in our state of Kerala, palliative care units almost invariably engage with the community. And when we do that, miracles happen. In the image, there's a man standing behind. He is Mr. Francis, who initiated a palliative care service in his village. This elderly woman with a walker had fallen down and fractured her femur. The hospital did a fixation, did a pin and screw and everything. But the woman would never have walked again. She would have been lying there at home in the village. And in a few weeks, all her muscles would be wasted. She would never walk again. The man made sure that a volunteer went over ability, encouraged her to get up. Our physiotherapist and doctor and nurse would visit them every week. But the local volunteer made sure that she was made to walk. And her total recovery was caused by the community, not by the doctors who got the surgery done. This is the benefit of engaging with the community, and because the community gets engaged, when you visit Trivandrum to us, you will see this happening. We are now educating about 300 children from families of patients who we treated. You don't have to do it. None of the doctors has to go behind it or nurses. The community does it. Volunteers do it. Our volunteers identify every child, or the clinical team identifies families where there has been a financial destruction by the disease and there is a problem. And then they go and treat the social problem of the children. They raise funds to make sure that the child goes back to school. And every year they get them all together for 3 days of fun and camp. One more example of what the community can do. How did we define healthcare? Remember, health is not only absence of disease, but physical, social, and mental well-being. On a palliative care day, this event was caused by engineering college students. 160 students came from 2 engineering colleges. 4 of them in a one vehicle, there were 40 vehicles. 4 of them in one vehicle to a patient who was bedbound. Many of them paraplegics, never going out of the home except to go to a hospital. So they physically carried the patient and a wheelchair, brought them to the road, put them in the vehicle, and brought them to the event in the seaside. And these people, some of them for the first time in their life, felt the sea. You see that girl in green and red? She is a paraplegic. She does not have normal sensation in her legs. She said, the waves touching my feet was the best experience that I have had in my whole life. Is that healthcare? That's the height of healthcare that we doctors and nurses cannot do ourselves. This integration can happen at the macro level with a national policy. I'm glad to say that the National Health Policy of 2017 includes palliative care at the primary level. National level trainers and state level trainers have already been trained. Working with the government, now that Tamil Nadu also will have a certain number of state level trainers trained, it's much easier now to get it across to primary health centers and make it happen. meso integration is in a hospital or in the university, what better examples? If all, when all, I shouldn't say if, when all institutions and healthcare institutions under Tamil Nadu, M.G.R. Medical University integrate palliative care, wonders will happen. And of course, it can also be micro level, like Dr. Rajavayyar is doing within her hospital, within her department. There will be obstacles. Change is always resisted. People are not used to doing this way. If you start tomorrow and go to the hospital and start asking patients, do you have pain? A senior person may scold you. What silly things you are doing? This is not what you are supposed to do. There will be resistance to change. People will be afraid. People will be angry. Hey, do you mean to say that we have been doing things wrong? But with patience and persistence, they will gradually get to adapt themselves to the new way of doing things. And then they will feel the enjoyment. Just as you are going to feel the enjoyment next week when you go to see a patient, and instead of being very arrogant and wearing your uniform and all, you go and all smile, so that when you smile at them, maybe touch an arm and say, you seem to be suffering a lot. We will help you. You will see the difference. You will see how enjoyable the healthcare can be. Sorry, I skipped that. This shows the important changes that have happened in the country recently. NDPS law, the law governing opioid medicines like morphine, was changed in 2014. A national program for palliative care was created in 2012. And as I said, the national health policy includes palliative care. MBBS curriculum now includes it. Nursing curriculum now includes it. And specifically in MBBS curriculum, as Sridevi can explain later, there are 20 modules newly brought in since 2017, which are related to palliative care, including pain relief, end-of-life care, attitude, ethics, communication, etc. And they are distributed from the foundation course when they join the medical college to the internship. And working with Sir and this university, we will all make sure that this is taught after the faculty is trained in teaching them. What we now have is a massive online open course. It's on our website. Anybody can access it. Any healthcare provider can access it and do the course. This is for our MBBS people now. But we will have to develop the course for other specials, other medical fields also. And we have had a few faculty development programs done already. And with the leadership from this university, we can get a collaboration of institutions and hospitals and scale up faculty development programs and make a miracle happen. If you look at all the suffering in Tamil Nadu as a mountain of grief, we are going to chip away from it and make it vanish in a certain period of time. Thank you very much for listening to me patiently.
The next thing comes, what is that you all have to know to treat? I will try to give some salient information in Tamil also. First of all, to know what is pain. As the definition is quite big, basically the definition of pain was given in 1979 by an organization called IASP. What does that mean? It's an international association for study of pain. So basically, it is a world body to decide what everyone has to know. And why should we all learn or know about pain? The reason is that pain forms nearly 60 to 80% of the symptom that all of you will have to know to treat if you are going to do palliative care. Because pain and breathlessness are the two main symptoms that all will have to know to manage. To manage something properly, we first need to know what it is. So basically, என்னன்னா ஏதாவது ஒன்றை பத்தி அது சிகிச்சை கொடுக்கணும்னா அது என்னன்னு உங்களுக்கு ஃபர்ஸ்ட் தெரியணும் இல்லையா? தெரிஞ்சாதானே அதை பத்தி நல்லா தெரிஞ்சுக்கிட்டீங்கன்னா நல்ல ட்ரீட்மெண்ட் கொடுக்க முடியும். ஸோ அதனால பேசிக்லி ஃபர்ஸ்ட் டெஃபினேஷன், வாட் இஸ் பெயின்? இந்த டெஃபினேஷன்ல இம்பார்ட்டன்ட் words alone I will mention, because the whole thing what is there, all of you can read. Can everyone read what is there on the slide? Okay. In that case, the important things are, it is unpleasant. Then it is sensory and emotional. Another next important point to note is whether the damage can be actual or potential. So what does actual or potential mean? So actual means direct, there could be a cut or an injury. Or potential means there need not be a physical cut. Normal example what I give is when anyone has surgery, retraction, nurses, நிறைய nurses இங்க இருக்கீங்கன்னாங்க. ஸோ ஒரு சர்ஜரி பண்ணும்போது ரிட்ராக்ஷன் பண்ணுவீங்க ஸ்ட்ரக்சர்ஸ் எல்லாம். அப்போ நர்வ்ஸ் வந்து டைரக்டா கட் ஆகிறது இல்லை, ஆனா அதுல புஷ் ஷியர் அப்படின்னா அது இடத்த விட்டு நகருது. ஸோ அந்த மாதிரி ஆகும் போதும் that is also an injury, that is called as potential injury. So directly there need not be a cut to have pain. Okay, see, pain, so much about pain has known so that it is dealt properly. Okay, and on top of that, the whole definition which was given in 1979 was changed or added on or made better in July of 2020. For 2 years they had many people working on it to make this definition better so that people will know more about pain and pain will be treated well. Okay, and so they added on 6 additional features to it. What are they? First thing is that pain is always a personal experience. By that, what they're trying to say is there is some biophysical element to experiencing pain. Next, pain. What is pain? What is nociception? That difference has to be known, which we will see in the next coming slides. And life experience has a role. To explain this more, for example, when someone has pain and also has some life incidents happening along with it, that will have an impact on their pain. So for example, someone has a big physical or physical pain is there, but emotional element, loss of someone or a physical insult, emotional insult. So that is associated with the pain. The pain will present differently. Next, we have to respect someone's expression of pain. For example, if someone says they are in pain, generally it is said, அது வலி எல்லாம் ஒன்றும் ரொம்ப பெருசு இல்லை, நீ பெருசாக்குற. Those type of statements we should never ever say and never ever compare. I know someone has the same cancer, he's not having pain. Why are you having pain? These type of statements should never ever be said. So என்னன்னு புரிஞ்சுச்சா? நம்மளா இன்னொருத்தங்களுக்கு வலி இருக்கு இல்லைங்கிற டெசிஷனை நம்ம பண்ணக்கூடாது. அவங்க வலின்னு சொன்னா அதை வலின்னு அக்செப்ட் பண்ணி ஒத்துக்கணும். Next is, generally pain is taken as something. For example, normal example that I give is right side of the abdomen, if there is pain, it is said as normally appendicitis pain. So that pain helps you to diagnose generally. But sometimes if the pain continues for a long time, or in the Kudukkapadi, pain usually is said to have an adaptive intent, but may have adverse effects too. When the same pain prolongs for a very long period of time, then that becomes a disease rather than a symptom. Okay, last one, verbal expression, that is someone telling I am in pain, is not the only mode to express pain. From morning we have been listening, we see patients in ICU. Do patients in ICU speak? No, they may have tubes in all orifices. That is, they may have a tube in the mouth, they may not be able to speak. Does that mean that they are not in pain or they cannot express pain? No. Here only, as Dr. Rajagopal sir said,
இந்த ஒர்க் ஷாப்ல பாலியேட்டிவ் கேர் பத்தி நிறைய இன்ஃபர்மேஷன் நாங்க தெரிஞ்சுக்கிட்டோம். இப்போ இந்த கேன்சர் பேஷண்ட் மட்டும்தான்றது இல்லாத பெயின் மேனேஜ்மெண்ட் இதுல ரொம்ப முக்கியமானதுன்றதை தெரிஞ்சுக்க முடிஞ்சது. ஸோ இந்த வாய்ப்பளிச்ச எம்ஜிஆர் யூனிவர்சிட்டிக்கு ரொம்ப நன்றி.
இந்த பெயின் மேனேஜ்மெண்ட் அப்படிங்கிறது அந்த பாலியேட்டிவ் கேர்ல வருது. அப்போ எல்லா டிசீஸ்லயுமே வரும். மோர் ஓவர் நாங்க சித்தா சிஸ்டம் ஆஃப் மெடிசன்ல இருக்கும்போது எல்லா டிசீஸ்லயும் பார்க்கும்போது கிரானிக் டிசீசஸ் தான் நாங்க ட்ரீட் பண்றோம். ஸோ திஸ் பாலியேட்டிவ் கேர் வந்து ஸ்டூடெண்ட்டுக்கு வந்து ஐ ஓப்பனரா இருக்கு. தேங்க்யூ வெரி மச் ஃபார் த M.G.R மெடிக்கல் யூனிவர்சிட்டி ஃபார் கண்டக்டிங் சர்ச்சா செஷன்.
இன்னைக்கு வந்து நாங்கள் என்ன பார்த்தோம் அப்படின்னா, இந்த பாலியேட்டிவ் கேர் அப்படின்றத பற்றி நாங்கள் பார்த்துட்டு இருந்தோம். ஒரு டிசீஸ் இருக்குது அப்படின்னா அதில் மெடிசன் எவ்வளோ முக்கியமோ அதை விட அதிகமான எமோஷனல் சப்போர்ட் வந்து முக்கியம் அப்படின்னு சொல்லிட்டு தெரிஞ்சுது. ஸோ அந்த ப்ரோக்ராம் தான் இன்னைக்கு வந்து என்ன அனௌன்ஸ் பண்ணாங்க அப்படின்னா, BSc Palliative Care அப்படின்னு சொல்லிட்டு சொல்லியிருக்காங்க. அண்ட் ஐ வுட் லைக் டு தேங்க் M.G.R யூனிவர்சிட்டி ஃபார் கிவிங் திஸ் ஒண்டர்ஃபுல் கான்ஃபரன்ஸ்.